everyone. Today we are joined, of course, by the very lovely Dr. Robyn Thompson, and we are going to discuss what happens when your waters break. Now, of course, the proper term for this is actually your membranes breaking, right, Robyn? And this is usually a healthy indication of the early active stage of labour. I say usually, but how are you doing, Robyn? Thank you for your time again.
All right, you might see it's a bit cold here, so.
And look, for once here in the UK, we are blessed with good weather, and Robyn is wearing her gilet because it's cold over there. So
yeah,
I'm not jealous for once.
no.
Where are you based in the world? Let us know. And are you pregnant or watching on behalf of somebody that is pregnant? Today, we hope to answer a lot of your questions. I know these were burning questions for me during my last pregnancy. So, like I said, this is the lovely Dr. Robyn Thompson, and we are here to answer those questions. So, Robyn, how do we know if our waters have broken?
Well, I can speak from experience. I can also speak from women's experience telling me, and I can also speak from my midwifery experience as well. So how do we know? We have a leaking or a wet feeling. If that happens, it depends. Or if there's a full cupful, then you know that the volume is decreasing. So, yeah. So it just depends on the medicalised term is ruptured membranes, but they're actually ruptured by someone if they're ruptured. So generally, I talk about the membranes breaking because that's a spontaneous thing.
Yeah, I think that's very similar to how the language is used here in the UK as well. Because, like you say, when they're ruptured, they are physically ruptured manually by someone. Yeah, I think for me, in my experience, I always wondered, oh, how am I going to know? How will I know? And it doesn't feel like you're going for a wee, going to the toilet, because you can't stop it. You can't control it. There's no flow stoppage there. And for me, it did.
Well, it depends. There can be a slowing down of it if it's a hindwater leak, and we'll talk about that later.
Yes, that is a very interesting point, actually.
There is a distinguish between the two.
Yeah, and of course you will know, I think, if you're connected to your body and your pregnancy, you'll know the difference anyway as you're experiencing it. But we want to hear your experiences. What did it feel like?
And there may be no breaking of the water if the baby's born in a cool. And
that is a very beautiful thing to see. As I was doing my research for the show today, I did see some beautiful babies perfectly born in the sack, and how amazing that is. So yes. Do let us know your experiences, ladies.
Yes.
So what should we do if we do know that they've broken? What should we do when they have broken, Dr. Robyn?
First of all, it depends how instinctively they are reacting and feeling. The mother's feeling might take a breath for a minute and might say, oh, what's happening? Something's happening. Or is it with contractions? Is it without contractions? Is it with Braxton Hicks? It depends where you are in your pregnancy. And how does it feel? Does it feel like there's just like I've got wet knickers? Or does it feel like, wow, I've wet my pants?
It can be either, can't it, really? And I think, like you said. So what are the things that we should look out for?
Well, I would be, if I was the midwife and privileged to be seeing this, but I would talk with the mother about, if I'm talking with her about looking at the colour of it first, is there, and I'd be looking at things like in the midwife brain, is there any blood involved? Is there any meconium involved?
Yes.
They're the things that, because sometimes there'll be a small amount of blood if the mucous membrane, if the mucus plug hasn't come away, and then suddenly there's a gush, and that all happens too. So there's no one answer to any of this really. But my midwife instinct, which I learned way over 50 years, around 50 years ago, was, and from my own experience, way over 50 years ago, was wafting, because the smell is so sweet. It's so sweet. So it's sweet like the baby. And if there's no other major problems or complications, the first thing I would do as a midwife is ask the mum to smell, and then I'd have a little sniff too, and we'd say, oh yeah, that's pretty sweet, isn't it?
Yeah, and that was actually exactly what I was as advised during pregnancy with my first. And we were actually told, hold off if your waters have broken, and you haven't had any contractions, just give it some time, just to relax unless you feel the need to come in, and come in within 12 hours. Although I know that advice does vary. But yes, color, amount, and odor, those are things that are regularly told to keep an eye out for.
Yeah,
So
and it's changing hydraulic pressure within the uterus around the baby too. So even when it's leaking, that's still changing the hydraulic pressure, but not as rapidly as if the forewaters rupture. And then the hydraulic pressure changes more when people rupture the membranes and push the baby up a bit to let more out.
yes.
And that does change the whole progress of labour.
Yeah, that's for sure. Very interesting that I learned that in the last few days. So should you go to hospital straight away? I know we were discussing this earlier, and we discovered that different countries have so many different rules. What are your thoughts?
Well, my thoughts are that the mother always knows best. Her instincts and her knowledge will guide her, and what's happening with her body and her brain in the moment. So it depends on how long she might have been pre-labouring, early labouring, depending on whether it's a first, a second, or even her 10th baby.
It happens.
There's a whole picture different for each mother. So if we work with the mother and listen to her, she'll guide us as to what she needs to do most often. I don't panic anybody or rush them, depending on their history. If their history's been a healthy pregnancy, then there's no need to rush anything. However, how far do they live from the hospital if they are going to the hospital? If they're able to stay home, can the midwife be there? They're the sort of questions that come up. So again, there's no one answer. It's in the moment for that mother at the time and her baby. What her baby's doing too, because if her baby's progressing rapidly, she'll know exactly where her baby is and what it's doing. And if we are midwives with her, we'll see all the changes that take place with her to know where she's at and what she's doing. We don't need to do vaginal examinations, most of the old ones. We can actually observe what is happening by her facial expression, by her sounds, by her body movement, and how she changes and turns. We can do all of that. And the worst thing we can do is put her flat on her back.
Yes, absolutely. And thank goodness there are new studies emerging on this as well. Yeah. And I'm really interested in a point you made there, that it depends on the situation, because a majority of women do birth in the hospital, and a majority are not living closely because of the lack of local community resources at the moment, especially in the last 20 years or so. So many have been dropping off across the world, not just here in the UK or in Australia. So you have to consider that travel, which for a lot of first-time families is quite scary. But we have a comment coming in from Leanne, and she said, yep, broke your water with no contractions, go take a nap. You're going to need it later.
And it depends again whether she's broken her forewaters or her hindwaters again. And yes, if you can take a nap, not every mum can take a nap, but it's something that some mothers can do.
Yeah, I was too excited, I think, at that point. It took about 3-4 hours for my contractions to start. Although I think I'd been in labour for a few days, but just as a lot less actively. But yeah, I think it's so unique, isn't it? How you feel. Some people are packing their hospital bag. They're so last minute at that stage. So it totally depends. So what happens?
That was good from Leanne. That was good from Leanne, because we do need, because everybody's different. So we do need to have those perspectives around it too.
Yeah, for sure. And absolutely, if you feel like having a nap, I would definitely recommend catching up on as much sleep as possible. Thank you so much, Leanne. We hope that you're well. So what happens then if your waters break and within, say, any time limit, let's imagine, you don't experience any contractions? What do you say on that?
Okay, so I'd be wanting to know what happened days before. What's your estimated gestation of the baby, what colour the liquor is, do you have any instinctive knowledge you'd like to share with me, how are you feeling, that sort of thing. Unless there's an emergency situation, I wouldn't be rushing anything. But again, it's always good to know that there's sort of, for example, no cord presenting. So we don't do a vaginal examination to do that, but we can talk about those sorts of things, you know, and listen to the baby's heart rate with the mother's permission, with her consent, and with her consent palpate where this little baby is, how it's lying, what position it's in, how far has the head descended into the brim, you know, and what she's feeling. They're the sort of things that I would be doing, and certainly listening to the baby's heart rate.
Yeah, and of course you'll be able to feel baby's movements and if there's any change.
Yeah.
You know,
that's from the midwife's point of view. The mother will share lots of information about what's happening, and sometimes you only have to listen. You don't even have to specifically ask either.
Yeah, for sure. Oh, it does bring back lots of memories for me, for sure. So let's talk about now contractions without waters breaking. So let's switch it up a little bit. So having your waters broken, can we talk a little bit more about that and what circumstances would arise where some professionals may consider doing this?
You mean artificial rupture of the membranes?
Yes, artificial manual rupture of maybe not the membranes, but usually actually breaking the water. So beyond a sweep.
That's it. That's breaking the waters. Artificial rupture of the membranes, or it's different to a sweep. A sweep is between the cervix and around, and you know, interfering with that part there.
And sometimes the waters can break during a sweep, right?
Oh, absolutely, they can break them. Yes, and not meant to, but they do. And a sweep is very painful. You know, just think about that. The women that are agreeing to that, just think about the pain that you may experience with that, and you know, the discomfort that goes with it all, the mental experience that you need. I've never swept membranes in my whole 50 years. Never.
It's something that's very common now in the UK. The new NICE guidelines suggest offering a sweep of membranes
that's
at 9 weeks.
That's accelerating labour. That's not appropriate, and I don't care what the guidelines say, that is not appropriate from experienced midwife's point of view. We should do the least amount of intervention that we can do.
Yes, and many don't understand that it is actually a form of induction. It is a form of induction. And of course, every woman is unique. And hey, you know, we are the first to always advocate for women. That is your choice. And we just want to make sure that you can do that based on an informed decision. So breaking off the membranes, what are the risks of this, Dr. Robyn?
Rupturing the membranes is changing the hydraulic pressure. That's the first risk for me. And when you change the hydraulic pressure of a little baby that's in there comfortably and you just let all the water out, what is that little baby doing? What it's reacting to? Why are we doing this to this baby? Then for the mother, the uterus then comes in absolute contact with the baby's body and skin, so that increases her pain enormously. Then her uterus is contracting and retracting right against the baby's body, where normally there would be some fluid. It does fall to the lowest level so the baby can drink. And if it was a breech baby, every now and then we might change position to give the baby a little drink, because they do drink in labour. And the reason we know they drink is because they get the hiccups. So,
and it helps them pass that first all-important meconium period as well.
And if you think about it, the hydraulic pressure is made for the muscle to work with the descent of the baby, contraction and retraction, and the hydraulic pressure builds up to a point where it then needs to rupture itself. You know, unless the baby's born in a caul. And I've had a number of babies born in a caul, and a number of babies born in the water in a caul and come to the surface in a bubble, and mum breaks the membranes around them. Oh,
how beautiful.
And gradually peels them back at her leisure, because there's no rush. If everything's all right from the observational point of view, then, you know, there's no problem. I've had, you know, many babies born in a caul.
I wonder how many more babies would be born in a caul. Is that the term for it? If there were less interventions. So many arrive at the hospital without their waters breaking, but labour's going perfectly well. They're contracting, but they break the water. So it's happened to my mum.
To accelerate the labour, most times it's in order to accelerate the labour, because the profile now is to be in, through and out as quickly as you can. That's the isation syndrome, the systemisation.
Yeah, and
polytheisation.
I'm sure many viewers can relate to that. It is such a rush, no matter how much you plan and how much you advocate for yourself, there is definitely a feeling and a sense of rush. So another question from Leanne, Robyn. Sorry.
Yes. No.
She said,
Yeah.
do you guys use TACO, which is time, amount, color, and odor? And actually, Leanne, if you go back a little bit, skip back a little, we did discuss this, and Dr. Robyn did suggest using those things, right, Rob?
Yeah, yeah. And the amount will mean if you've caught it, if it's a full
Yeah.
rupture. But if it's trickling, that's a hindwater leak. And sometimes if you do have a nap and lie down and rest, the hindwater leak or the hindwater membrane may even close over again. And that's sort of also depending on gestation and what labour, what you've been doing leading up to that. So there's no one answer, but it's what the picture is at the time. Yeah. So all of those things, yes, we have just had a little chat about those.
Yeah, no, Leanne, don't apologise. It's perfectly okay. We're really glad you've joined us and brought
Yeah,
up
no,
the question.
that's
Someone
good.
else may have missed it. So that's very helpful. Thank you again. So what if my waters break then before 37 weeks? So we haven't quite made it full term. What would you suggest considering at this point? Of course, we can't advise, but
I can't advise because it has to be on an individual, unique basis for each mother. But I've had many babies born at 37 weeks and they're not regarded as premature babies. So they've been able to breastfeed, they've had no drugs, they've been able to do all the things that they need to do. In fact, a colleague of mine had a 35-weeker not so long ago. So, and didn't look back. I've looked after 1.8 kilos babies at birth, 2 of them. And they did surprisingly well. And you know, she had a pediatric friend who actually came to the house and said, "Oh my goodness, everything's fine. No need to go into the hospital." So the prematurity can be different though. Like the estimated prematurity can make a difference on how the baby behaves, but it depends on the baby's, when you're watching the APGAR score and when you're watching the baby's ability to do what it needs to do, then, you know, and being sure that the baby is fed frequently, that's the important part then. So there's not, see what I mean? It doesn't mean that there's one thing, but it doesn't mean to say that we are sticking to this rule because that every woman on the planet has to do this at this time. We are all genetically different. We are all biophysiologically different. We are all unique in our way. We are anatomically different. We are neurologically and psychologically unique as well. So we cannot say that everything, but it does work in the medical model that way.
Yeah, it does.
And unfortunately, a lot of midwives are becoming medicalised because that's the only experience that they're having. And we do need to come back to midwifery being a profession in its own right. And in its own right means that she works with that, she's working with that particular woman in her unique situation, and preferably one-on-one where the woman knows the midwife, you know, and they've had a relationship.
That would be so ideal, wouldn't it? One woman, one midwife.
Yes.
There's a campaign for that, and I think it would change birthing and breastfeeding experiences worldwide. So obviously the majority, the common factor with premature babies born born much before 37 weeks.
Very premature babies will depend on the circumstances, and yes, some of them might need a nasogastric tube in.
Yes, help with finishing their growth, which they hadn't had the chance to do yet.
But as long as I believe, and through my colleague who was in charge of a NICU, big NICU, 250 staff.
Wow.
If they do need lots of intervention or they do need help with breathing, she still had those babies on their mothers.
Yeah.
And, you know, that was just such a warm and beautiful place to be. CPAP going, babies being breathed, and still with their mothers. They knew how to.
That lovely smell and skin to skin.
Yeah, and they did very well. They did really well. So I think that's probably one of the major factors, is try as hard as you can to keep that mother and baby together for intervals that are appropriate for both the mother and the baby. And, you know, you can still do nasogastric feeding, but, you know, we still have to be very careful about our techniques and what we do. We don't want to create more problems. So
and that's why preparation is key. Actually, is something that I'm I have a rhetoric of it now. We're always saying it because actually you can have all these wonderful plans, home birth, water birth, and things sometimes they don't go to plan, and sometimes intervention is necessary.
Yes.
And you can make an informed decision at that time on what to do, and instead of making a decision based on fear, which is what you say, isn't it?
And most preferable is not to give the baby animal milk. If you're going to feed this little baby, it needs to be maternal milk. So we have a responsibility to understand how milk production is made and how milk production works in the human body, and then work with that mum with the respect and the knowledge that we have for her baby to be able to have her milk. And we do not have to rush it.
Have options when they're in this situation. There's donor milk, and also we have an entire mega post, an entire module on this in the online education on stimulating hormones to produce milk when you can't physically breastfeed. So it's important to understand, like you just said, how that body works to produce.
Yes, and how you can get that beautiful rhythm and cycle going that then brings the milk for the baby, and it doesn't take too long once the baby's born.
Yeah, no, I've seen some beautiful Thompson Method stories of mums who've had babies in the NICU for 10 weeks. One of the ladies I spoke to had 10 weeks. Baby was so small when she was born, and so needed so much help. But baby fed on the breast the first time in hospital. Midwives were amazed. And then that routine that she had established continued perfectly at home as well. So proof is in the pudding, right?
Yes.
We've got some lovely questions here. So Christy has said she shared her own experience of her pregnancy. Waters broke on their own, but because she had a stomach bug. So then she was given lots of intervention at the hospital, and she's asking, do you think this had an effect on breastfeeding? Because she had lots of nipple trauma. Well, we know what you think about that one, don't we, Robyn?
Well, it's a bit hard to answer that directly without knowing the detail. But if she had a stomach bug, I would want to know what the bug was and what they were treating it with. That would be the first thing, because that will affect the baby's gut. There's no doubt. People say things don't come through the milk, but they actually do. And I see these babies every day online with mothers, and I see the baby's behaviours changing. Depends on the birth. It depends on a whole lot of factors, not just one. But yes, it can have an effect on breastfeeding, but also because, and it depends on the whole big picture. So to answer that, absolute, Kirsty, it's really hard without chatting and having a detailed history. It's not.
It does. It sounds like Christy had a lot of interventions, like a cascade of interventions.
Can I just say, if you had someone pushing your baby to the breast, it's highly likely in my research that you will have nipple trauma.
And I will share a video with you once the session's finished. I'll catch up with you and share some really helpful explanation videos that Robyn has in her
and if you are pushing the baby to the breast and directing the nipple to the nose, it goes up behind the gum in the corrugated area, and the nipple will be damaged very quickly. And I have no doubt about that whatsoever. The nipple is not meant to be up behind the gum in the roof of the mouth. It glides along the middle of the tongue with the baby's vacuum.
And we have a lots and lots. There's a wealth of information on this and on how interventions may possibly affect labour and pregnancy decisions may affect breastfeeding, and how you can avoid that. There's lots we've covered recently, and the more we will cover in the future. So thank you so much for your question there, lovely lady. And then we have Faye Louise, who says, I'm currently taking your online course, Dr. Robyn, and she's 34 weeks. Congratulations. And she said, it has made me feel so much more at ease that my instincts are going, and how I monitor my own labour. And she says you're very motivational, and she just wanted to say thank you for giving me
that's
strength.
Lovely. Thank you.
That's beautiful.
Yes, we certainly need to have informed women and taking your journey, not taking everybody else's journey. This is your journey with your baby. Of course, there'll be times when you need help or your baby needs help, and that's where the care or the complementary services are applied. But not just as a routine, people doing things to you or coming in and out and worrying you over something that does not need to be done.
That's a very wonderful answer. And we're so happy you shared that with us. Thank you, Faye Louise. Best of luck very soon. You'll be meeting your precious little one. I can't wait to see an update in the club. So our final question then. Leanne, I will get back to you. Yes. Well, we don't have a book yet, do we, Rob?
I want to have a book out, Leanne.
Yes, she has a title.
I just don't have the time.
She's very busy. It will happen. But there are lots of resources. I'll connect with you afterwards. And let me just run this along the screen for you. If you want to learn more about Dr. Robyn and the Thompson Method, then comment yes down below. And I will connect with you personally, and we will have a chat and share some resources and ask away with any questions you have, Leanne. But it's been a pleasure chatting with you today. So thank you for watching. And I can't wait to speak to you in a mo. But the last question I'd like to ask you, Dr. Robyn, is what are forewaters and hindwaters? Because I have no idea. It's so confusing to look into.
You know, the uterus is a pear-shaped organ, right? And there's a little baby in there. So inside there are the membranes, and the membranes come right around the inside, all the way around the shape of the uterus. And in there, the water is there for the baby to be able to move comfortably, the baby to be able to drink. And it's interesting because I was talking about this at a conference, and a radiologist said, "What are you talking about?" And I said, "Well, babies hiccup when they drink." And he said, "Oh, I'm going to have a look at that," he said. And I'm thinking, no more ultrasounds, just ask the mother.
Yeah, I would love to have that conversation with you.
And they're in fetal position, so they're a little bit, squished in that area. So they'll hiccup easily when they've had a drink. As they grow bigger and longer in their body when they're born, the hiccups start to spread out. They don't ever go away because we all hiccup at some stage. But they're not as frequent as they are when they're drinking in utero, and that hydrates them for after they're born. For the first 3 days, their cells fill up with the beautiful nourishment from the mother, the liquor surrounding them, and what the mother's providing for them through the placental flow, and then they can gradually build up the maternal milk supply over the first 3 to 4 days.
And actually, that's posed another question for me, as you explained the perfect pear shape of the uterus. So how do we know, where are the forewaters, the hindwaters?
Okay, so sorry, I hadn't quite finished. I'm glad you reminded me. So
no, go ahead.
The hindwater is it's called a hindwater leak, and it's generally a little hole around the back of somewhere. It can be forward, but most often when you're talking with the women, they can feel it happening with the drip. So it's a tiny pinhole or a little hole. It's not. So when the bag of water is in front of the head, baby's head is the buffer. It's the buffer on the way down, and it's the buffer because the uterus is contracting and retracting. So as the baby's negotiating the pelvic bones, that buffer is perfect. Sometimes it does rupture naturally, and that depends on a whole range of things which we can't cover here now.
That's very true.
But it's there as a buffer for the baby's head coming through, and it also is soft as the baby's making its way onto the perineal muscle, on the perineal muscle, because it's starting to stretch 8 different ways. And so if it's still there, then that's a bonus. But also, so that's the forewaters. That's that bag. So when that bag of waters actually breaks, I was about to say ruptures, as it actually breaks spontaneously, there's a gush of water. And
so
people
are there 2 bags technically?
No, one.
So it's literally behind and in front of the baby.
One's a pinhole and one's a whole rupture of that pressure that's built up in there. That's a rupture of that. Or it can rupture before that, where some of the hindwater will leak down through the forewaters as well. And that's generally a harder labour when that happens, and it's more so if the membranes are artificially ruptured. Unless it's absolutely necessary, please don't artificially rupture the membranes just to accelerate a woman's labour.
Yes, yes, indeed, a very strong message to share. So that has cleared up a few things for me. And is there anything you'd like to add about how
I
discuss these things with your midwife?
I'd be keen to listen to the fetal heart too, just to see how the baby's coping with all of this. I'd be hoping to understand that if I was with this mother, her descent of her baby and her behaviour and how she's dealing with that descent, because, as I said before, she knows. And by knowing the baby's descending, then we know the labour's progressing. And, you know, people talk about how it's obstructed, but lots of times there's a little fist there.
And actually, I take note that you have not once suggested, oh, just do a vaginal examination, because it actually doesn't tell you much anyway. No. My midwife said that she prefers not to do them, thank goodness, because there's no training that can be in place for how different the progression can be for each examination anyway. You could be 2 centimetres and regress very quickly, or 9.
If a midwife is educated, she will know what is right in the moment with that mother, because that mother will be guiding her. And that's the skill of listening and the skill of observing. And so she will do things if the mother indicates, and she will do it with consent, legal consent. She won't just be bombarding that woman's body with a whole lot of things. It's not the way to go. In an emergency, I must cover this, then the senior obstetrician, not the juniors, not the young ones that are learning, the senior obstetrician will make decisions.
Yeah, for sure. And this is something that you can consider and communicate in your birth plan. So
yes,
definitely important. So Kirsty said, thank you so much. And she said, yes, my then nurses did force my son on the breast. This is in reference to a question earlier in the show, because I had a lack of education last time. But this time, thanks to the course, another club member. Thank you both so much. It's our absolute pleasure. My daughter will be here soon, and I'm so much more confident. That just makes your heart sing, doesn't it?
Beautiful. Well done. Yes. And stay strong. Listen to those little voices in your head, because they're going to talk with you all the way.
Yeah, for sure. Yeah. Thank you so much to those that have watched and those that have taken part. If you have any other questions or you'd like any other topics discussed, pop us a message. Let us know if there's anything you'd like to learn. I'm going to be back next week with a lovely story from one of our members on her difference with experiencing the Thompson method compared to the forceful techniques that she learned in her previous journey. So that should be very interesting indeed. Robyn, did you have any of your wonderful mind to share with us before we go?
Do I have my wonderful mind?
She's too modest. She's just
I'm not allowed to say that it's deteriorating.
No, it's
not. Look, I just say to all the beautiful women, please be guided by what you think is appropriate for you. Now, it depends on your history. We do a lot of things without even thinking whether a mother might have been sexually abused. We do not even consider that in our practice most times. Not all the time, but most times. And so I'm saying to you, you lead the way. And I'm saying that as a suggestion, it's not a controlling mechanism. It's not what you have to do. It's how you need to guide your journey for you and your baby with the people that you have chosen to be with you. That's very important, because if they are really with you, they'll be watching carefully too. They'll be listening to you, and they know you better than any of us do, midwives as well. I think one day somebody's going to ask me where my broomstick is.
No, I think the world is desperate for suggestions like this. I think, you know, although the times are tough and the medical institution is really under pressure, when you know these things, you can really seek them out. I'm not going to be able to afford private midwife care in this pregnancy, but with the research and the maternal knowledge I have now, I've been able to be a bit more selective in how my team is built. And I think we're very fortunate in the UK anyway with our NHS.
And look, there's some wonderful midwives in the UK, really wonderful midwives. You know, Sarah Wickham, that does all the beautiful research and has the education, and there's Deborah Niger, who I read her stuff, and they all come to my heart because we're sharing information, we're with you in a very similar way, because this is your journey. And if you need help, we can help to arrange that, even if you're at home. And if we are tuned into you, we would be moving into a hospital sooner rather than later, because we are understanding you and we're knowing you, and preferably knowing you through pregnancy too. So, you know, there are some brilliant midwives in the UK. I know they're having a difficult time at the moment with all that's going on, but they are wonderful, and they've set this wonderful journey over many, many years. There's many more than just 2. I just can't go through all of them.
Well, you've always got so many beautiful words to say about a lot of them. And we regularly share Sarah Wickham's information, because she's a lover of informed decision making, which is
absolutely, and she's brilliant the way she does the research. And she reviews all the research, so it's not, she's actually very, very clever at that.
Yes.
And
it's not jargon. It's easy to understand and interpret.
Brilliant skill.
Yeah, wonderful.
And I know Deborah Niger goes for miles to see women, and she's very there with the woman from what I'm reading with her. I don't know her personally, and I don't know Sarah personally, but reading their material, or their information, Robyn, not material, it's their information. I'm trying to change my language too. It's very, very important to understand what it is you need, and how you need it, and with whom you need it, where you might like to go. Have you spoken with the people that you might go to? And if you haven't, make an effort to do that with your plan that is suggested by you, and that you will, under any circumstances that is an emergency situation, rely on the senior medical obstetrician to do that, to be with you.
And hopefully, because the majority of births do go smoothly, hopefully that won't be you anyway, and you will have the birth that you so deeply desire. And we hope that the suggestions made today, and the information that we've shared with you today, and the wonderful brain that Dr. Robyn so humbly says that she does not have, has helped you in your journey, because I know it for sure has helped me once again. So thank you so much. We know it's very late for you in Australia, so we do appreciate your time and your brains.
It's only 10 to 6. It's not bad.
Oh, but you've been working all day.
Yes.
As you said earlier, for almost 50 years, you've provided this, so we do appreciate it. But thank you as well, especially to all our beautiful, lovely viewers. Whether you're pregnant or sharing with someone that's pregnant, please do, whether you're watching here with us live, watching the replay on YouTube, click and subscribe so that we can help as many women as possible across the world. That's our aim, right?
Thank you, Chelsea. Thank you so much.
Thank you so much.
All right.
Take care, guys. See you soon.